Alright, ventricular. We're finally going to do our ventricular rhythms. So now, you want to remember, these are starting in your ventricles. Now, your rate for your ventricles is, like I said, between 20 and 40 beats per minute. Your normal ventricular rate, if it's coming from your AV node, that's going to be from, it's 0.12, less than or equal than 0.12, which is about 3 boxes from beginning to end. So remember, that's really narrow because you're fitting your Q, R, and S in there. Your ventricular rhythms are usually going to be wider than that. They're going to be premature. They're going to be irritable sites. They're going to look wide. They're going to look crazy. This is when you get into like the fun stuff, like your ACLS and your PALS. So let's get started. All right. You have a rhythm that I previously never heard of, interpolated PVC. This is a PVC where the overall pace and rhythm of the heart is not altered by the ectopic beat. So what I gather with interpolated just means that there's no compensatory pause after the beat. Remember, I was saying there's a compensatory pause just to make sure that everything's on the right rhythm. So with this, there's no compensatory pause. And I'm assuming this is like your trigeminals and your bigeminals, where you have a sinus beat and then a PVC. A sinus beat and then a PVC, and then it seems as if they are all, even the PVCs, are all marching out on the rhythm. Those are called interpolated. Use that word next time you're talking to somebody. You also have a ventricular, you have your ventricular escape beats. Now remember, escape means late. So these are the beats that are protecting your heart from extreme slowing or asystole. So the most funnest in the world beat is the idioventricular rhythm. The idioventricular is extremely fun because idioventricular usually looks just like the friggin' junctional. It really does. But the way they always help me to remember is that your idioventricular is always going to be wide. So this is a PVC. If you have a PVC beat, which they wouldn't call it PVC beat, they call it the idioventricular rhythm. Oh God, the pen would die right now. It kind of looks like that. I know it's really funky. There's no narrow QRS, but that's the way you're going to tell the difference between your junctional and your idioventricular. Both of them don't have a PAC. Both of them have a slower rate. Your junctional rates are 40 to 60. Your idioventricular a little bit slower, 20 to 40, but you know, you can have an accelerated idioventricular. You just want to remember your idioventricular is wide because that's coming from your Purkinje fibers. Your junctional is going to be narrow because that's coming from your AV node. All right. The ways to treat this, you want, if they're symptomatic or if they're dead, you want to check for a pulse, throw some oxygen, check vital signs, IV, EKG. In particular to these, you want to possibly think of atropine. That's how I always think of it, atropine. The atropine is supposed to be speeding up the heart. Atropine. It's probably not helping anybody. And then you're also going to transcutaneous pacing. It doesn't look like that, but that's what I think of. You put one lead on, you put the other lead on, and it's like boop, boop. And then if they're awake, they're like, ow, 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 because it hurts. Let's see, some of the medications you want to consider with this are dopamine, epi, and isoproterenol. I can't say that. I've never really used the isoproterenol, as you could tell, but I've used the epi and the dopamine. Remember, the rate is going to be between 20 and 40 beats per minute, and their QRS is wide. Now, with your accelerated idioventricular, that's 41 to 100 beats per minute. That's also benign. It's regular. The QRS is wide. I saw a guy, oh no, he didn't have accelerated ventricular. He had a junctional rhythm, an accelerated junctional, because it was about 75, 80. He had been doing coke, I think, all night. So I guess that normally happens. I guess people have drugs or whatever. Um, so now your accelerated idioventricular is going to be going from 41 beats to 100, and it's going to look like that. Now, your fun beat is going to be your ventricular tachycardia, or VTach. That's the one that everybody is always concerned of. This is exaggeration because I can't draw. But your beat is going to look like that. I swear, it really is. If you see that, you need to call a code right away. Well, obviously you want to see like if they're awake, but even if they're awake, I would still call a rapid response team, code team, get the doctor by the bedside immediately. That one, if it's obviously longer than 30 seconds, if it's sustained, if it's like 3 beats, you know, you don't want to be concerned, but you still want to get an EKG, maybe even get a chem panel and get a recent set of vitals and let the doctor know that it happened. You have 2 types, polymorphic VTach and monomorphic VTach. Mono means one. It's coming from one place in the heart, so it's going to look exactly the same all the time. It's always going to have that same look. Monomorphic is just boop, 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 that big sawtooth. Polymorphic means it's coming from different places in the heart, so it's going to have, I forget what people label it as, but it's sawtooth, but it's going up and then down and then up and then down. If you look it up and you'll find it. I think that's called torsades de pointes or something weird like that. But they usually give mag for that one. Again, you won't be doing any of that. You just ask the doctor. You just let them know that that's going on, but you definitely want to have them on some pacing pads and a monitor and the 12 lead and vitals and oxygen and all that good stuff. So a monomorphic VTach is going to be the same shape and amplitude. With the VTach, if they're awake, you're not going to start CPR, but chances are they're not going to be awake. You're going to check for a pulse, and if they don't have a pulse, you're going to immediately start CPR, immediately. If they're stable, if they're awake and they're looking at you and they're like, hey, I'm feeling a little something in my chest. You're like, oh my God, you have a VTach. You're going to look at some antiarrhythmics and you want to put some oxygen on them. The antiarrhythmics that you're thinking of are procainamide, amiodarone, and sotalol. I usually hear of amiodarone, and I figured out why now today too, because apparently procainamide and sotalol you don't want to give if there's a prolonged QT, and you don't want to give procainamide if they're having any kind of heart failure, which they're, VTach doesn't have to be directly related to heart failure, but a lot of times people who have having heart issues have heart failure. So amiodarone is probably going to be your normal choice. If you have that unstable VTach, which means they're not awake, you're going to cardiovert, you're going to have IV, you're going to have some oxygen. With your polymorphic VTach, it varies in shape. It kind of goes from wide to thin, from wide to thin. If it's stable, you're going to give amio, mag, and beta blockers. If there's no pulse, you're going to immediately go to CPR and defib. If you always remember immediately go to CPR, you will do well in everything. Okay. Ventricular fibrillation is similar to VTach, but it's a little bit more narrow. It looks more like this. These are easy to draw because they're pretty simple. That's considered the chaotic rhythm within the ventricles. This is like where you have AFib, where you have VFib, where your ventricles are fibrillating, just like that. If it's 3 millimeters or more, 3 millimeters, it's coarse VF. If it's less than 3 millimeters, it's fine VF. I never knew, I just always kind of eyeballed it. But 3 millimeters or more is coarse, 3 millimeters less, it's fine VF. That one again is CPR and defib if they're not awake. You're not going to start CPR on somebody that's like, hey, what are you doing? But 9 times out of 10, if they're having fine VFib, they're not going to be talking to you. And next is asystole.